probably still favor, in some instances, open surgery to certain cases, but I'm going to talk to you about the concept of CERAB versus kissing stents, and does it really matter? Um, just get the whole context clear. We're going to be talking about the iliac occlusive disease, where in the past, particularly the task C and Ds, were very much favored to have open surgery. And that traditional approach may still be the case in many centers, but there's no doubt that there's an evolving strategy that we all need to be very aware, very familiar. And it is now considered to be still the most appropriate fashion to go with an endovascular first technique for task C and D lesions as well. So when we talk about endovascular, what are we actually talking about? So it's not just kissing stents and CERAB, and CERAB, most of you will be very aware, covered endovascular reconstruction of the aortic bifurcation. But we can even talk about EVARs, although very expensive for occlusive disease, but sometimes that's reserved for patients where they've got aneurysmal disease or pending to have aneurysmal disease that requires treatment. And you'll now see a lot more literature around intravascular lithotripsy, either with or without stents, and that's with or without covered or bare metal stents as well. So there are many different options, but we're going to focus once again as to why sometimes we consider kissing stents and sometimes why we consider to have CERAB. So we know that the concept of kissing stents, it's quite a cheaper procedure to do, it's a quicker procedure, and it has had good results for many, many years. But there are issues regarding the radial mismatch, and you'll see this study which looks at the physiological or reviews the physiological hemodynamic considerations here. And the radial mismatch, the altered flow dynamics, where you get some recirculation zones, possibly increases the risk of developing some intimal hyperplasia, thrombosis in the gaps. And this may or may not be partly responsible for the restenosis and the reduced long-term patency in the idea of kissing stents for the aortic bifurcation. Now, a number of you will remember the covered versus balloon expandable stent trial, the COVIS trial 2011, which looked at this group of patients and noted that if you look at task B lesions, there wasn't really much of a difference. Both were good in terms of primary patency. But when you started to look at the more complex aortoiliac lesions, and particularly those with the task C and D, that the covered stents in the iliacs did favor and were better. I'm not talking about CERAB in this case, but still just the concept of having a covered iliac stent versus to have a bare metal. And that argument has been going on and on for a long time. And some people might even say there was some biases within this COVIS trial that they don't necessarily reflect their practice. But this trial did actually look at it in up to 2016 when we looked at the retrospective post hoc analysis of the COVIS study. So you're looking at long-term 5-year data. And the point about the 5-year data, that variation between bare metal and the covered stent was even more stark. And there's more data in terms of this meta-analysis, although of obviously just non-randomized trials, 47 studies, which also came to the same conclusion, particularly in task C and D, using covered iliac stents was more favorable in terms of primary patency compared to using the bare metal stents. So what is now the physiological rationale for CERAB itself? Well, CERAB is essentially creating a more anatomical reconstruction of the aortic bifurcation. And most of you who've been involved with this will notice that the gaps or those areas of flow recirculation zones will be less. And therefore, theoretically, this has an advantage in terms of the longer term patency. When I say theoretically, there is, of course, some evidence which I'll present shortly. But when you look at the in vitro, the CT-based studies around the CERAB compared to kissing stents, those reduced areas of turbulence and reduced related flow disruption seem to have some benefits in terms of the outcomes that we see later on. Now, I think we've obviously got one of the leading author, Dr. Hani, who's obviously in our room here today. And this study, which has only just been published this year, gives us a bit of a clearer long-term data. It's a UK multi-center real-world data, and some of you may have read it already. It's a retrospective analysis included by 85 patients. I think it was something like 117 or so initially, but those who were excluded included the one from one center and then a number of other patients who were excluded without full data sets. But nonetheless, we have 85 patients that you could identify and follow up their data for at least 5 years. And what we're looking at here is the freedom from target lesion reintervention as a primary outcome measure. And the interesting thing here, when you see it, is probably not that surprising, is that target lesion reintervention of 16.5% for CERAB would be quite favorable, particularly when you start looking at the 5-year major amputation rate, 2.4%, and the 5-year mortality. And remember, the mortality obviously isn't obviously peripheral arterial disease related mortality, is all-cause mortality. But it did highlight that the long-term outcomes of CERAB is something that we should consider as being almost equivalent to that of open surgical repair. It's a durable revascularization option with really acceptable morbidity, mortality, and patency rate for this complex group patients. But this is the real big question behind what we all have to think about when we practice is the cost effectiveness. And this study that was published this year as well from a Dutch healthcare perspective is looking at a 5-year time horizon. This is more of an establishing. They had real world data for CERAB and kissing stents, but they used for open surgery the published literature to do the extrapolations and estimations. But some of the data won't be surprising to you. So if you look at open surgical repair, it has the lowest reintervention rate. And I think that's certainly something that's nobody can deny. The kissing stents, CERABs, kissing stents have a higher reintervention rate. But the cost itself is stark. So, of course, with open surgery, the initial head-on costs, 26,000 euros estimated versus 9,000 or so for kissing stents and 14,000 for CERAB, allows them then to go on to look at the quality assessment. So this is now looking at the incremental cost effectiveness ratio. In other words, how much does it cost to give you a quality of life benefit over another treatment modality? So when you look at CERAB versus open surgical repair, well, clearly there's quite a lot of reduction in the quality in the initial part after open surgical treatment. So the conclusion here was CERAB is superior to open surgical repair in terms of the financial side. But CERAB versus kissing stents, here's where the problem is. The actual quality benefit is much less than you imagine, but the cost is significantly more. So it costs 110,000 thereabouts euros per quality. And that did not meet the Dutch willingness to pay threshold, which is 50,000 euros per quality. And so that's something to keep in mind. So just to conclude really quite quickly on this one, when to choose kissing stents versus CERAB versus open surgery. This is just an idea based on observational evidence. I'm not going to go through it step by step, but if you're young, fit, and you can manage an open surgery, still consider it. If you're got a very complex anatomy, think about CERAB versus considering kissing stents, particularly if you're worried about embolization or rupture of plaque. And these are the limitations of all what I've just said there. The evidence is not that strong still. It's missing a lot of randomized controlled trials. And the guidelines themselves leave it fairly open to the user to consider which one they want to go based on their preferences predominantly. But do think of a endovascular first option in these cases and consider the anatomical or physiological considerations. Kissing stents still remain a good option for simpler iliac disease, but it's a very much individualized treatment, anatomy-driven approach. Thank you very much.
Thank you, Dr. Bagunid. You can sit with us, please. You can call Dr. Ahmed Effendi, please. Is he around?